Hello and welcome back to Pathways in Pediatrics, the official podcast of the European Academy of Pediatric Societies, or EAPS. It is great to have you with us.
It's good to be back.
We're continuing our journey through, just the mountain of science that came out of the EAPS 2025 Congress in Lisbon back in October.
It really was staggering, wasn't it? Just the sheer volume and quality of the research presented.
Absolutely. So for those of you following along, you'll know we've been breaking this down into key themes. First, we looked at neonatal and early life care.
Fascinating stuff there.
Then last time, we dove into the very complex world of infectious diseases and immunodeficiencies.
Both huge topics.
Huge. But today we're shifting focus a little. We're looking at something that wasn't, a single track you could attend.
Yeah.
It was more of an overarching theme that you felt in almost every discipline.
Chronic conditions and long-term management.
Exactly.
And it's such a critical topic because if you think about pediatrics, say, 30 or 40 years ago, the whole game was about survival.
Right. Acute management. Get them through the crisis.
Exactly. Get them to their next birthday. But now, because of all these incredible advancements, we're playing a different game. It's the long game.
From surviving to thriving.
Precisely. The whole goal of the sessions we're about to discuss was really about that shift. It's about quality of life, mental health, self-care, and of course, the breakthroughs that make it all possible.
Okay, so let's start there. With that idea of self-care, there was a session by Immacolata Dall'Olio that, it really challenged how I think about that term.
Oh, that was a fantastic presentation.
It was, because self-care in, popular culture means one thing, but she was talking about something very, very different.
Completely different. And she made a point to say that for the 16% of children in Europe living with a chronic condition, self-care isn't a luxury. It's work. It's labor.
She broke it down in different components, didn't she?
She did. A really clear model. First, there's self-care maintenance. That's the day-to-day stuff, taking the pills, doing the exercises.
Yes, grind.
The grind. Then there's self-care monitoring, which is more about, listening to your own body.
Okay, so is my breathing tight today, or do I feel a bit off?
Exactly. And that leads to the third part, self-care management, which is the action. Okay, my breathing is tight. I need to use my inhaler.
And for so long, all of that it fell on the parents.
100%. The parent was the manager. But her whole argument, and this is the big shift, is that we have to deliberately transfer that agency.
From the parent to the child.
Gradually, yes. Because if that child hits 18 and has never learned to manage their own condition, well, that's a recipe for disaster.
It's a cliff they fall off.
It is. And it's not just physical.
Yeah.
She talked about 6 dimensions: physical, emotional, cognitive, social developmental, and mindfulness.
Mindfulness. That's an interesting one.
It is, isn't it? But it's about being present with your condition without letting it overwhelm you. But the key takeaway for me was, we don't measure this stuff.
We don't measure agency.
No. We measure blood sugar, we measure lung function, but we don't have a good instrument to measure how well a child is actually engaging in their own care. And if you can't measure it...
You can't support it. Okay, but here's the thing. A child isn't in a vacuum. They spend most of their day at school.
Right, and school can be a bit of a black hole when it comes to healthcare coordination.
Which leads us right into a presentation by Ignacio Valverde Benitez on the role of school nurses in Spain.
Such a practical, on-the-ground talk. He made it so clear that for kids with complex conditions, we're talking diabetes, cerebral palsy, severe asthma, the school nurse isn't just for scraped knees.
They're the coordinator.
They're the central hub. He basically described a triangle: the hospital, primary care, and the classroom. The nurse sits in the middle of that.
And without the nurse, that job falls too.
The parent, who then can't work, who is constantly on call. The burnout is immense.
And his data showed that having these nurses actually keeps kids out of the hospital.
It does. It reduces emergency visits. But he also pointed out that the policies need to be better. It's not evenly distributed. It's about making sure every child with a complex need has that support structure in place.
So we've got the child and the school. But what about the emotional toll, the trauma? I was really struck by Ursula Goransky's session on ICU diaries.
Oh, that was a powerful one. She was talking about PICS, post-intensive care syndrome.
And the numbers she shared were just shocking.
They were. PTSD rates in families of ICU patients can be between 30 and 60%.
60%. So more than half of families could be walking away with significant trauma.
Yes. For parents specifically, it's as high as 50%. And the reason is, You lose the plot.
Yeah.
Time blurs in the ICU. There are alarms. You're terrified. Your brain has these memory gaps.
And it fills them in with the worst-case scenario.
With nightmares, yeah. So the ICU diary is a cognitive tool. It's not just a scrapbook. Staff and family write in it. Today is Tuesday. You had a fever. Your grandma visited. It rebuilds the narrative.
It helps them make sense of it all afterwards.
It does. We know from adult data it reduces anxiety and depression, but she pointed out a really interesting nuance for kids. Parents and children want different things from the diary. Parents want the hard facts, the numbers. The kids, though, they often really dislike the scary entries.
That makes sense. A kid doesn't want a detailed log of how sick they were.
Exactly. So there's this tension. Who are you writing it for? There are privacy issues to figure out, but it's such a simple, low-tech intervention for a massive problem.
So speaking of leaving the ICU, what happens next? There was a great talk from Varvara Mputapilo about, well, bringing the hospital home.
Yes, on a program in Greece for transitioning long-term PICU patients. And she made this really useful distinction between common chronic illness and complex medical needs.
Right. These aren't just kids with well-controlled asthma. These are kids who might be on ventilators.
Correct. And for those families, going home is terrifying. The hospital feels safe.
So what's the solution in this Greek model?
It's nurse-led. They've empowered specialist nurses to be the core decision makers, using telenursing and a 24/7 link to the hospital.
So you still have that safety net, but it's in your living room.
It changes everything. It's expanding from 3 to 10 hospitals by late 2025. It allows a family to just be a family again, not hospital visitors.
Let's pivot now to the biology. Because sometimes the long game changes because the science itself just takes a giant leap forward. And we have to talk about cystic fibrosis. Rishi Papari's update was incredible.
It's a revolution, truly. If you learned about CF 10 years ago, you need to relearn it. Papari was talking about CFTR modulators like Kaftrio.
So explain the difference. Old treatments versus this.
Okay, so old treatments were about the symptoms. The mucus is thick, so you bash the chest to clear it. You get infections, you take antibiotics.
Reactive.
Totally reactive. Modulators go to the source. They fix the broken protein that causes all the problems in the first place. Papari explained it as a 1-2 punch. You have correctors that help the protein fold into the right shape and potentiators that prop the gate open so it can work.
And the results are?
The wow factor. That's literally what he called it. We're seeing lung function and BMI improvements we never thought possible. But the really exciting part is starting them early, in infants.
You stop the damage before it even happens.
You might even reverse some of it. He talked about rescuing pancreatic function, preventing lung scarring, and even improving fertility in women with CF. It's a whole new world.
But there's always a but.
The remaining 10%. The patients with what are called nonsense mutations. Their body doesn't make any protein to fix, so the drugs don't work for them.
So for them, the hope is?
Gene therapy. Using a harmless virus to deliver a correct copy of the gene. That's the next big frontier.
Okay, so let's talk about CF's lesser-known cousin, Amelia Schumark, presented on primary ciliary dyskinesia, or PCD.
Yeah, and it is so often missed. She said it affects about 1 in 7,500 people. Basically, the tiny hairs in your airways that are meant to sweep out germs, they don't work properly.
And clinically, that looks like what?
A wet cough from birth, a chronic runny nose, and the big clue, in 50% of cases, is cetus inversus.
The organs are mirrored?
Heart on the right, liver on the left. You'd think that would be an easy spot.
You would. So why is it so hard to diagnose?
Because there's no single magic test. She really emphasized this. It's a puzzle you have to piece together. You need genetics, you need to measure nasal nitric oxide, and crucially, you need high-speed video microscopy.
You actually film the cilia moving.
Or not moving. You take a sample and you watch them. That's how you confirm it. And catching it early is everything for preventing permanent lung damage.
Right. Shifting from the lungs to a much broader topic, obesity. Martin Wavich's presentation really turned the old eat less, move more idea on its head.
It did, and it's such an important conversation. He argued that we have to stop looking at it as a failure of willpower and start understanding the biology. He focused on the set point theory.
The idea that your body has a weight it wants to defend.
Exactly. Your hormones will fight to keep you at that weight. If you diet, your body thinks it's starving and fights back. He explained that bariatric surgery works because it actually lowers that set point by changing your hormones.
And now we have drugs that do something similar.
Semaglutide, tirzepatide, yeah, they mimic those hormones. But the crucial insight, And this is the tough part, is that this is a chronic disease. The trials are clear. You stop the drug, the weight comes back.
So we're talking about long-term, potentially lifelong therapy.
We are, but it destigmatizes it. It's not a character flaw. It's a metabolic condition that needs long-term management, just like asthma or high blood pressure.
And none of this works. Not your metabolism, not your mental health, if the foundation is cracked.
Yeah.
And that foundation is sleep.
Absolutely. We had 2 great talks on this. Virginie Bayon on obstructive sleep apnea. She split it into 3 types.
Which is helpful because I think most people just think big tonsils.
That's type 1. And for them, yeah, taking out the tonsils often works. But type 2 is in obese children, where it's not just tonsils, it's other tissue. And type 3 is syndromic, like in Down syndrome.
And she talked about a tool to figure out which it is.
DICE, drug-induced sleep endoscopy. You put the child into a light sleep, and you actually look with a camera to see where the airway is collapsing. It's targeted.
And then Paul Greengrass took sleep into the neurodevelopmental world.
He did. He pointed out that sleep is when the brain literally builds itself. It's called cortical remodeling. So for kids with ASD or ADHD, where insomnia is so common, it has a huge impact.
Any practical tips from him?
He said melatonin can be very effective, but, and this is the key, it has to be paired with behavioral interventions. It's not a magic pill. And he talked about teens and social jet lag.
Every parent of a teenager knows that feeling.
But it's biological. He was clear about that. Their internal clocks actually shift later. So it's not just them being difficult, it's their circadian rhythm.
So when we pull back and look at everything, from fixing a protein in CF to writing in a diary after the ICU, what's the big picture here?
I think the big picture is that we're moving away from static labels. A child isn't just a diabetic. They're a person on a developmental journey who also happens to have diabetes.
And the goal of modern pediatrics is to build a support system around that whole journey.
Exactly. A scaffolding. A scaffolding made of new biology, better psychology, smarter environmental support in schools, and empowered families at home. It's about managing a life, not just treating a disease.
That feels like a perfect place to end. We hope this look at chronic conditions has given you some new ways to think about the long game in pediatrics.
These talks from Lisbon really show the path forward. It's an exciting time.
It is, and we'll be continuing these conversations in person. The next EAPS Congress is already on the horizon. We're all heading to Athens.
Can't wait for that.
So from the 24th to the 27th of September, 2026. So mark your calendars. Until then, thanks for walking these pathways with us.
Take care.